81 batch.
83 batch, sir. So
ஓ நீங்க 83 ஓகே. அப்ப நீங்க எங்க பாலகிருஷ்ணன் ஏகாம்பரம் இவங்கள உங்க பேட்ச் மேட்?
ஆமா ஆமா சார்.
ஓகே ஓகே. நான் 82.
Okay.
Good evening, friends. With the permission of faculty, Srikumar sir will be joining shortly. That's what sir said. So we have yet another edition of the PG Clinics. This week has been dedicated to vascular disorders. We have upper limb disease and lower limb disease, both contributed by Professor Srinivasan sir from Coimbatore Medical College. Thank you, Srinivasan sir. And we have the invited faculty from Savangi. You have Professor Yashwant Lature. Thank you, sir, for joining us. And we have Professor Dr. Prakash. He is from Kumaran Hospital. He has done his masters and vascular from MMC. Later, he has spent more than 8 to 10 years in United Kingdom, and he is now has his vascular practice in Coimbatore.
दिव्याम जा रहे थे.
And we have Professor R. Srikumar sir from Trivandrum Medical College. He is in charge of the vascular unit at the Government Medical College, Trivandrum. And we have eminent faculty, Professor Kanna sir, Professor Jailal sir, Srinivasan sir, Karunakaran sir, and I could see other professors, Dr. Srihari Rao, Dr. Ahmadullah, and all other seniors have come. I also warmly welcome the faculty and students in the YouTube. So thank you for joining us. Then let me ask Dr. Prabhu to present his case first, then we can have Jacob one after the other. Faculty, kindly take over. Srikumar sir, good evening, sir.
Good evening, sir.
I would request all the participants who are not participating, please keep your mic in mute. Sir. Kindly request you to do that. Thank you very much.
Extra. Oh, abhiya. There an extra. Extra, sir. Oh.
So please go ahead, sir. Faculty, take over. Tambu, please share your PowerPoint and start your presentation.
Okay, sir.
Can I make it full screen, ma? Best wishes.
Yes. Good evening, all. I am Dr. Prabhu, General Surgery Postgraduate from Coimbatore Medical College. I am going to present a case of upper limb arterial disease. I would like to thank my chief and guide, Dr. Professor T. Srinivasan sir, and my HOD, Dr. Professor Lakshmi Narayani ma'am, and my assistant, Dr. Vijay Shankar sir, Dr. Jayalakshmi ma'am, and Dr. Balasubramani sir. 65-year female, farmer by occupation, from Ooty, come with complications of pain in the left upper limb for 2 months. Weakness of the left upper limb for 20 days. History of presenting illness. Patient was relatively asymptomatic for 2 months back. After that, she noticed pain in the left upper limb for 2 months. Initially, it was intermittent pain aggravated during work, relieved on rest. Now, for past 20 days, continuous pain involving whole left upper limb, aggravated on moving the limbs. No specific relieving factor for past 20 days. She complains of weakness of left upper limb for past 20 days. There is no history of fever, recent trauma, neck pain, restricted neck movements, chest pain, palpitation, breathlessness, transient background, headache, seizure, blurred vision, abdominal pain, and similar illness in the other limbs, and loss of appetite by loss of weight. Past illness. History of similar illness. No history of similar illness. The past history of COVID positive 3 months back, managed by home quarantine. Comorbid illness. There is no history of diabetes mellitus, systemic hypertension, cardiovascular disorder, tuberculosis, cerebral vascular disorder, epilepsy, thyroid disorder. Family history. There is no significant family history. Personal history. She consumes mixed diet. There is no history of smoking, alcoholism, or betel nut chewing. Sleep and appetite pattern was normal. Bowel and bladder habit was normal. Obstetric and menstrual history. She was P2, L2, both full-term normal vaginal delivery. Antenatal, natal, and postnatal periods were uneventful. There is no history of contraceptive use. She attained menopause 15 years back. Post-menopausal period uneventful. Treatment history, there is no history of chronic drug intake or native medication intake. And there is no history of drug allergy. Summary of the history: 65-year-old post-menopausal woman, not a smoker, not a alcoholic, with no comorbid illness. History of COVID positive 3 months back, managed by home quarantine. Presented with pain in the left upper limb for past two months. Initially, it was intermittent claudication pain. Now past 20 days, it was progressed to rest pain and associated with weakness of the left upper limb for past 20 days.
You can wait. Professor Srikumar sir, good evening.
Yes. You in the history, you
Yes,
told
sir.
about history of COVID and all those things. Can you
Yes, sir.
elaborate something about COVID? History, anything significant? Any evaluation done after COVID also?
Sir, patient not at all went for hospital for COVID, sir. She not at all investigated or not at all admitted in the hospital, sir. She just done investigation for COVID and she managed in home quarantine itself, sir.
So here is a case of thrombosis. Though it's a medical problem. So
Yes, sir.
how will you assess the thrombosis issue of a COVID, of a post-COVID patient, or during COVID?
I would like to do blood investigation like CRP and D-dimer levels and serum ferritin levels. If it is elevated, it's a high risk for developing thromboembolic event, sir.
Okay, then what will you do? If these
Uh,
markers
sir-
are high, what will you do?
Sir, during acute event, I will start her on heparin and anticoagulant like heparin, and after during discharge, I will start her on oral tablet like aspirin and clopidogrel, sir, and atorvastatins.
Okay. Okay, forget about COVID. So what are
Okay,
the
sir.
possibilities you consider in this patient?
She was a
With this
post-menopause.
history.
Go back to
Sir,
go back to the first.
Go back to history.
Sir, it's a 2 months duration with pain and weakness of the limb. I will suspect thrombotic and atherosclerotic event.
Thrombotic atherosclerotic event.
Yes, sir.
Yes. What are the any history important? Thrombosis. She's a working woman.
Yes, sir.
Any significant symptom?
Sir, weakness of the upper limb leads to for past 20 days she's not working, sir.
Not working because of the weakness.
Because,
Yeah. Is it what is the cause? What may be the cause? Is it arterial, venous, or neurological?
probably arterial disease.
Why?
Sir, pain and weakness.
What is the picture of a
Probably-
neurological TOS?
More of a pain and weakness.
Yes. That's again pain and weakness. So how will you differentiate
sir.
these two in the history wise?
So in neurological weakness is more than the pain, sir.
Yes. Then
Uh,
any history of edema?
Sir, there is no history of edema, sir.
Okay. Then next slide.
Defining what kind of weakness? You are just saying weakness.
Yes.
What is the weakness he has, and what is the exercise? You said pain is aggravated by exercise. What
Yes,
is the
sir.
exercise aggravated pain?
Sir, abducting the limb and flexion of the elbow and flexion of the fingers, sir.
Take in a clinical patient will not be able to say that abduction.
Okay.
What the patient's complaint?
Unable to lift the left upper limb, sir, and unable to grip the things with the left hand.
Grip, holding it.
Yes, sir.
So it is heavy. Okay. You think that a neurological deficit is significant one there, or it is only because of pain she is not able to do that?
Sir, neurological deficit also significant here, sir. Because patient is unable to flex completely, sir.
Flex also.
Yes, sir.
So do you think still you want to attribute it to the vascular cause or the neurological cause more? That is what Sarah is asking you.
Yeah. More towards the vascular cause, sir. Arterial cause.
Why? You are saying he is having a difficulty in flexing up the limb, not abduction, as you said earlier.
Yes.
Then
So more towards the distal weakness, sir.
Do she have any color changes?
Sir,
Any history?
no, sir, no stiff color changes in the limb, sir. Limb turns to pale, sir.
There is no bluish discoloration, only pale.
Only paleness, sir. No bluish discoloration or no gangrenous changes, sir.
One question I asked to Prabhu.
Yes,
See,
sir.
I am practicing in Coimbatore and I see these Ooty patients, thousands with
Okay,
all
sir.
these problems. So the problem is this patient a Badaga?
Yes, sir.
Badaga, yeah. That's a
Badaga
very,
only,
very,
sir.
very, very, very important point because both Sri
Okay.
Kumar and Dr. Jailal, they are not here in this part of the country. So Ooty patients, especially Badagas, they are very, very notoriously prone for, these sort of thrombotic diseases. So what is the reason? Any idea?
Sir, genetic disorders,
The genetic, that
Hyperlipidemia.
community for centuries, they never marry outside community.
Yes, sir.
So a lot of consanguinity, and there are actually a lot of studies have noted a lot of actually, in fact, thrombotic disorders in that particular community. So the fact that when you mention the patients from Ooty, you may make sure you mention the patients of Badaga, because that itself should point you towards some other causes for acute ischemia like sickle cell disease, which is again very common in that community.
Yes.
So just make a mention, Badaga, the patient's Badaga. Okay, that's a very
Yes.
important point. Okay, yeah, carry on.
Is it only in that community or is it?
That community is very notorious for thrombosis. I've been treated there. I'm not exaggerating. Varicose veins, you have done more than 4,000, 5,000 in that community alone. That's so common. Again, they're more prone for hemorrhoids. They're more prone for hernia. All sort of connective tissue disorders, connective tissue weakness. So that community, because we think basically the reason may be due to actually the community, they're not supposed to marry outside community. So that's why, now it's, of course, things are changing, but for many, many centuries that's been going on, and they are very prone for a lot of, these sort of diseases. Yeah, carry on.
Okay, thanks, Prakash. Many tribal communities are just like that only. They are not.
They're not tribal, but that's the way they have been. They call it Hatti. They live in a particular village, and you are not supposed to marry outside. And I know a lot of this, but now, of course, it's all changing now. Yeah.
Okay.
No, history wise, anything else, sir? Jaila, Prakash, or go to the history slide, second slide. What are the other histories you asked for?
lot of no history.
No
What
history.
about why there's fever?
Sir.
We said it's arterial thrombus. Will it produce fever?
Yes. Sir, if it is going for necrosis, it will cause infection and will produce fever, sir.
But the limb is normal here.
Yes, sir.
Yes. Other than that, limb is perfectly normal. On look, all fingers are there. There is no ischemia. There is no necrosis. There is no gangrene. Yes. Then will you still ask for fever? And if so, what's the significance?
Sir, endocarditis may cause embolic event which will produce fever in patients.
Okay, that's one possibility. Okay, endocarditis, then more in favor of chest pain. I prefer go to more chest pain because most probably post-ischemic endocarditis issues produce more embolus, but yes, still endocarditis also. Other than that, a lady with an upper limb ischemia, can they present as recurrent fever?
Systemic lupus erythematosus, connective tissue disorder, sir.
More than that, yes, maybe arthritis. More than that,
yes, sir. Okay.
Takayasu type arthritis, they can have a recurrent fever.
Yes.
So that's important. So second atherosclerosis, the common issue which happens in a female of middle-aged or after that with upper limb disease. Always you have to consider that Takayasu or any arthritis. So that's important.
South Indian arthritis?
Yes. As Jailas said, that's that. What is South Indian arthritis?
Yeah.
South Indian arthritis.
Jailal sir, உங்க மைக் சரியா கேட்க மாட்டேங்குது சார். South Indian arthritis பா.
Don't know, sir.
Sir, it doesn't know.
One history I want to ask, you said she had COVID 3 months back. Was she put on anticoagulants after the diagnosis of COVID?
No, sir. No, sir. This is not started on any drugs, sir.
Can we go proceed further, Prakash?
Yeah, sure.
No comorbid conditions. Okay, you proceed with the next slide, Pa.
Yes.
Then
And general examination, patient comfortable at rest, well built and moderately nourished, conscious, oriented, afebrile. There is no pallor, icterus, cyanosis, clubbing, edema, and generalized lymph. Yes, sir.
One thing is South Indian arthritis is a temporal arthritis, a giant cell arthritis, mostly report from South India.
Okay,
That is basically it's a pathology of giant cell arthritis, and location wise it is more in the temporal, affecting temporal arteries, seen
Okay,
more in females, middle-aged females it happens.
Okay, sir. Thank you. Yes. There is no pallor, no icterus, no cyanosis, no clubbing, no edema, and no lymphadenopathy. There is bilateral arcus senilis present. Vital signs: pulse rate in right upper limb 80 and left upper limb not felt. Right lower limb 80 and left lower limb 80. Blood pressure measuring in the right upper limb 110/60 mmHg, and left upper limb could not be measured. Right lower limb 120/60 and left lower limb 120/60. SpO2 99% in right upper limb and both lower limbs and left upper limb could not be measured. In right radial pulse 80 per minute, normal volume, normal rhythm. Vessel wall was thickened and no radiofemoral delay. Temperature was normal. Respiratory rate was 14 cycles per minute. Examination of the left upper limb. With the patient informed consent, adequate exposure in the sitting position, patient was examined. Inspection: left upper limb attitude was arm adducted, elbow extended, and forearm pronated. There is a paleness in the nail, fingers, and palm. There is a hair loss all over the left upper limb, and the skin appears shiny. There is no blackish discoloration of the nail or fingers, and no blackish patches in the skin. There is no edema, no ulceration. There is no supraclavicular fullness. The movement, painful, restricted movement present in the flexion of the finger and flexion of the wrist and extension of the elbow and abduction of the shoulder. There is no bony abnormalities. This is a picture showing paleness of the palm. Palpation: the left upper limb was cold to touch compared to cold to touch up to shoulder joint compared to the right upper limb. The sensation was present in the hand, forearm, and arm. Capillary refilling time was 10 seconds, and the pulse in right upper limb, right side axillary artery, brachial artery, radial artery, and ulnar artery felt normally, and left side axillary artery, brachial artery, radial artery, and ulnar artery not felt. There is no mass felt in the neck. The muscle girth. Mid-arm circumference on the right side was 18 centimeter and forearm circumference was 16 centimeter in right side. There is mid-arm circumference was 15 centimeter in left side, and the forearm circumference was 14 centimeter on left side. On auscultation, there is no bruit heard over the supraclavicular and infraclavicular fossa. The provocation test for right upper limb, adhesion test, ulcer test, and Rose test was negative. In left upper limb, the test could not be assessed due to absence of pulses. And peripheral pulse, other peripheral pulses in right lower limb and left lower limb, femoral artery, popliteal artery, anterior and posterior tibial, and dorsalis pedis artery felt normally. And head and neck, subclavian artery, right side and left side felt, and carotid and facial and superficial arteries felt normally. Other system examination, cardiovascular system, S1, S2 heard, there is no murmur, and respiratory system, bilateral air entry present, no other sounds. In abdominal examination, abdomen was soft, non-tender. There is no organomegaly, no visible pulsation, bowel cell presence. Summary of the history. Summary of the case: 65-year-old postmenopausal woman, not a smoker or alcoholic, with no comorbid illness. History of COVID positive 3 months back. Managed by home quarantine. Presented with pain in the left upper limb for past 2 months. Initially intermittent claudication pain. Now presented with 20 days, progressed to rest pain, weakness in the left upper limb for 20 days. On examination, upper limb was cold to touch, restricted movement, peripheral pulses are absent, prolonged capillary filling time, and there is muscle wasting and muscle wasting present with intact sensation. There is no gangrenous changes.
Prabhu, the initial, to begin with also, I have some different opinion about you, about the presentation. One thing is 2 points. One thing is, this affected side is left side. In principle, you must have started examination the right upper limb.
Okay, sir.
You never examine the right upper limb except some pulses, and that's so. Right upper limb should be given equal emphasis on examination, and that should be mentioned first. Then only you go to the affected side. Okay.
Okay. Yes,
second thing is left upper limb. You said about a radial pulse absent. You didn't mention about the ulnar pulse. You didn't mention brachial pulse or axillary pulse, supraclavicular pulse. Okay. So if the radial pulse is lost, there may be ulnar pulse may be present. Maybe selective radial artery disease or brachial may be present. So that also has to mention. One pulse is affected, then you have to go to the proximal pulse, see whether it is present or not. Okay. That also to be done. So these 2 points, you have done made a mistake in that examination part. Okay.
Sir, sorry, sir. I mentioned all other pulses, radial and ulnar pulses options.
But
axillary.
What about brachial?
Sir, axillary, brachial, radial, and ulnar all are also absent, sir, in left side. And but subclavian arterial pulse is present, sir. I mentioned. Sorry.
Yes. Okay. Then the normal lymph should be examined first.
Okay, sir.
Then go to the affected side.
Okay, sir.
If it is breast or if it is upper limb or lower limb, whatever it is, for a long case when you are presenting it, that should be examined first. Okay.
Okay, correct. I will correct it. Yes.
Okay. So,
as to which artery you are able to feel?
Sir?
You are able
sir,
to
in left side, subclavian artery only alone I felt, sir.
So
axillary, brachial.
No
sir?
Bruy, you said.
Yes, sir.
Why do you look for Bruy?
Sir, if there is any aneurysm in the subclavian
you are
artery.
saying axillary artery, you are not palpable.
Yes, sir.
You are seeing the subclavian artery, you are palpate the
Yes,
subclavian artery. Now,
yes,
why
sir.
do you expect the Bruy there?
Sir, any subclavian artery aneurysm?
Sir is asking how
Yes,
a
sir.
Bruy is produced in a vessel.
Turbulent flow in the blood vessel will produce the.
Is it a proximal stenosis or distal stenosis?
Distal to stenosis.
Stenosis. So you have the subclavian artery pulsation present, but axillary is absent. That means stenosis is where?
At the level of axillary.
Or above the axillary artery.
Yes, sir. Proximal to the axillary.
Then where do you look for the Bruy? Where do you look for the Bruy? After that,
the axillary.
That's the axillary artery. That is why Jailas is asking, why didn't you look for Bruy at the axillary? You said there is no Bruy in subclavian because it's a normal vessel.
Yes.
So in this case, you should have looked for Bruy at the axillary. That is why, that's what Jailas is asking.
Okay.
Many times the PGs are making this mistake because you say that it's actually a Bruy in the palpable artery. And there you will not see that. It's only the
sir.
proximal to that.
Okay, sir.
This is a neurological examination. Do you do any neurological examination?
Sir, sensations.
Sensation is normal, you have put.
Yes.
You are repeatedly saying there is a weakness.
Yes, sir.
So we quantifying that weakness, the reflex, that is nerves also involved. Fully putting it only a vascular issue. Even if it's a thoracic outlet, the neurological compression can be also there.
Yes, sir.
So any features you have checked for that.
Also, wrist drop, because one important sign you should be looking for any upper limb ischemia is wrist drop. Did the patient have any wrist drop?
No, sir. Patient not having stuff, sir.
Again, Prabhu, Jayala sir is asking,
Yes, sir.
what's the significance of a full neural exam? Because
No,
already
no,
there is wasting.
Yes, sir.
You said there is wasting.
Wasting, yes, sir.
Yes. What are the costs? Yes.
3 centimeter wasting in 20 days.
Yes, sir.
So what are the costs of wasting?
Yes, sir. Disuse atrophy, sir.
Yes.
Arterial occlusion
Yes.
causes weakness.
Yes. Will a neurological damage produce wasting?
When we are not using the limb, that muscle will go for atrophy.
That's disuse atrophy.
Yes, sir.
Is the isolated neurological injury, will it produce wasting?
When it go for contracture, it will cause wasting.
Before that, the neurologic supply is essential for maintaining the nutrition of the muscle. If
Yes,
there
sir.
is a neurological damage, non-neurological support, definitely that muscle go for wasting, even though there is an intact artery.
Okay.
So whenever they say there is wasting, three possibilities you have to consider always. There's ischemia, neurological damage, third is disuse. All the three has to be excluded by examination. Okay.
Capillary refilling time, we check for it. Is a refilling time or filling time? You are examined what capillary filling time or capillary refilling time?
Capillary refilling time.
What is the difference between capillary filling time and what are the refilling time? When you are measuring the vascular angle, Burgess test, and what you are looking for? And how did you do this capillary refilling time test?
Sir, in the nail pulp, sir, I will compress and relieve it for compress it for 2 to 3 seconds and relieve it if how much duration to it will take to for skin turn to pink color, sir.
When it is significant.
Sir, normal it is less than 3 seconds, sir. More than 3 seconds, it's significant.
Second itself.
Prabhu. Hello, Prabhu.
Hi, sir.
Sir, you're not audible.
Hello.
Yes, sir. Now you're audible.
Oh, capillary filling time.
Yes, sir.
Filling time by inspection, not by palpation.
Sir, please, your voice is breaking, sir.
Sorry,
His
sir.
connectivity is poor.
Connectivity is poor.
Sorry, my network.
Okay, can you go next slide, please?
Hello.
Yes.
Yes.
Yes, sir. Yes, sir. Now you're audible.
Yes, Prabhu.
Yes, sir.
I'm asking, have you measured venous
Your voice is still
filling time?
breaking, sir. Please.
Hello.
Yes, sir.
So you have some connectivity issues is there.
Yes, sir. Yes.
Yes.
Can
Can you move somewhere else?
Yes, sir.
Yes, sir. Yes, sir. Please. Move. Keep, sir. Any questions, Prakash or sir?
Yeah.
There. Go to the next.
Next slide, please.
Here
Okay,
you
this
will put Hudson test is not assessed, you will put, or you will put not able to, what do you, where you put?
Not assessed.
That means you are not done the test.
No, sir, not able to done because of pulses are absent, sir.
Prabhu, if the pulse is absent, then what you still you are suspecting clinically Hudson may be positive. The pulse is not palpable. Then what will you do? In this case, you said that a subclinical pulse is present or not? It's palpable.
Present, sir.
Yeah.
Palpable, yes, sir.
Yeah. Can you do absence then?
Yes, sir.
Yes.
By palpating the subclavian, actually,
Which
we
part
will
of the
stress-
clavin?
Sir, second part of subclavian.
No, third part. Second part is behind the rib.
Okay.
Yeah. Third part you have to palpate it because if it's first part or second part is not palpable. If you
Okay,
feel the
sir.
first part, Hudson is not significant.
Okay, sir.
Third part, if it is the pulse is palpable, you can do Hudson.
Okay, sir.
One option. Okay.
Yes.
Any other option? You feel clinically it's a thoracic outlet syndrome, Hudson may be positive. So you want to do Hudson.
By Doppler, sir.
Yes.
Using handheld Doppler.
Yeah, using a handheld Doppler, you can do it. Look for any signals, either axillary or the brachial, and if signals are present, you can do a Hudson's test.
Okay.
Okay, or you can hyperreduction test also, or military action deposition. Okay.
Yes, sir.
Yes. Okay. One thing is, you said that the right upper limb, left lower limb, you said that there's 2+ pulse.
Yes, sir.
But the upper side or even the right side has single plus pulse.
Yes,
Does it have any significance?
Okay. In lower limb, usually blood pressure was high, that blood volume was higher.
Normally, will you get a better person lower limb than the right limb? If it is so, what's significance? You have a patient with a very good pulse in lower limb, but poor pulse in the upper limb. Is it normal?
Yes, sir.
Normal. No. Upper limb has a better pulse. If you palpate anybody, if you look at the volume wise, ideally that should be normal. That is why your ABI is always 1. Okay. When you assess the ABI in a patient with lower limb, upper limb, it should be 1. Okay. So if you say that in this picture, you have a lower limb pulse are very good and the upper limb pulse are poor. That means some amount of aortic occlusion or subclavian brachiocephalic occlusion, some issues there in the upper part. Otherwise, this should not happen. Either your record is wrong or there is something else we are missing. Okay.
Prabhu, can you describe how do you do an absence test?
I feel the radial pulse, and I will abduct the shoulder and flex the elbow and ask the patient to turn the head on neck on the examined side and take deep breaths. If Hudson test is positive, it means pulse will not pulse or decrease.
No, Prabhu, it is not acceptable. You have to ask the patient to take deep breath, hold the breath, then only turn the neck.
Okay.
Okay.
Yes,
what is the anatomical basis of positive Hudson's test in thoracic outlet syndrome?
Scalene triangle.
Supposing you have a cervical rib and the Hudson's test is positive. So you have to ask the patient to take a deep breath. So why does the pulse disappear? Okay, see when the patient takes a deep breath, the heart goes down into the mediastinum, and the arching of the subclavian artery over the rib becomes more pronounced. So that's why there's a loss of pulse, temporal loss of pulse. This is anatomical basis. Okay.
That's why before the test itself, patient has to hold a complete breath. Hold the breath, turn to the same side. Then again you come back and release. Relax. Okay. Then only you get a positive outcomes. Yes. Next slide, please. Okay. Anything else, Jalal sir or Prakash?
Yeah, fine. We can proceed. Yeah, go.
Yeah. Then what will you do for this patient?
Sir, I will confirm my probable diagnosis was peripheral artery occlusive disease affecting the left upper limb, probably chronic limb ischemia. Probable cause is atherosclerotic disease affecting the left axillary artery level, sir. Artery level or proximal to the left axillary.
You are not. Yes, you are not considering thoracic outlet syndrome.
Sir, subclavian artery pulsation are felt, sir. So
will this TOS produce complete subclavian also absent?
no, sir. It will partially it will cause.
So in this patient, you will not consider the possibility of thoracic outlet syndrome. Am I right?
Yes, sir.
Reasons?
There is no supraclavicular fullness, or there is no mass felt in the supraclavicular region, sir.
In what percentage of patients you get a full rib? How will you classify the cervical rib? What are types of cervical ribs?
Complete and incomplete. In type 1, it is a complete bony component which will attach to the first rib or mandibular sternum, and second type is an incomplete type, incomplete bony type, and third type is incomplete at it connected to the ribs with the fibrous bands.
Yes. So
in type 1, it will produce mass.
You cannot just rule out thoracic outlet syndrome since it says no mass or there is no correlation.
Yes.
Sometimes we have fibrotic bands,
Yes,
which can be picked up only on an MRA. So just because you don't have a supraclavicular fullness or this thing, it doesn't mean that the patient doesn't have a compression at the level of the outlet.
Any clinical finding to suggest you as atherosclerosis? You have seen that. What are the things you will expect when it is atherosclerotic?
Patient is having old age and intermittent claudication pain is present initially, sir. Now progress to rest pain, sir.
So unilateral,
that is
bilateral.
Sir, unilateral.
Atherosclerosis has occurred in the one side.
Yes.
That is only in the right left upper limb. No other site is involved, and no other history suggestive of any atherosclerotic disease. It's a generalized disease.
Yes, sir.
So that is not a reason to accept atherosclerosis as a cause.
Okay.
If it's atherosclerosis, patient might have TIA or RIND or a CAD or lower limb diseases. Nothing like that. And patient is not a diabetic, not a smoker. Okay. Only old age doesn't mean atherosclerosis.
Okay.
What are the points in favor of considering this TOS or a cervical rib? I'm saying it's TOS cervical rib. What are
unilateral side, sir?
Yes,
female gender.
Yes.
Female gender.
Okay.
Pulse is absent from the axillary artery level itself, sir.
Yes. There is a significantly palpable supraclavicular pulse.
Yes, sir.
Okay. Either that may be a supraclavicular arterial aneurysm due to a rib compressing the subclavian artery.
Yes, sir.
That is one. And after that, there may be embolus, thrombosis.
Yes.
That's again possible. So if all the pulse are absent with a subclavian artery pulsations well presented, that's again suggestive of a thoracic outlet syndrome rather than excludes it. As sir said, there is no other features of atherosclerosis in this patient. So
Yes.
you cannot straight away make a diagnosis of atherosclerosis. Nothing is suggestive.
If there is a stenosis and there is a dilatation of the artery, will the dilatation be before the stenosis or after the stenosis?
So before the stenosis.
Before the stenosis or after the stenosis? You have a stenosis,
Yes, sir.
and there is a swelling on the artery. So before the stenosis or after the stenosis?
Sir, before the stenosis. Sir.
Let's say the patient has got a subclavian artery aneurysm.
Yes, sir.
And if you think the patient has a stenosis, will it be a stenosis before the aneurysm or after the aneurysm? Because we do have, like even last week I saw a patient with cervical rib with the subclavian artery aneurysm.
Yes, sir.
So in this case, it's called post-stenotic dilatation. Actually, the stenosis causes a jet, which causes the artery to dilate. So it's actually, you'll be seeing the aneurysm dilatation after the stenosis actually. Just because the artery is occluded, the artery doesn't become bulgy at before the stenosis. It's a post-stenotic dilatation. Okay. Yeah. Okay.
Yes.
I'm going to proceed.
Sir, I would like to do investigation to confirm my diagnosis, sir.
What all investigations?
X-ray C-spine.
X-ray C-spine. Okay.
Any bony cervical rib is present, sir. And ultrasound
Cervical
duplex.
spine or something else? You take a straight cervical spine only or something else?
X-ray neck. Sir.
Yes, X-ray neck with upper chest.
Yes, sir.
So if you take a selective cervical spine, you won't. They won't get. You won't get a cervical. You have a chance of missing it. Okay, fine.
Okay.
Okay, you took a X-ray neck with upper chest. You have seen suspicious. The radiographer is a poor radiographer. You have seen something suspicious there. How will you identify as a thoracic rib or a cervical rib?
Sir, cervical rib have a straight course, which will not go upwards direction and downward direction, sir. It will produce directly downward in X-ray.
No, I didn't get it.
In X-ray, cervical rib will produce directly downwards courses, sir.
Okay, then
Thoracic ribs will produce upward, initial upward direction, then downward direction course, sir.
what structure causes that upward downward direction? Is it a rib or something else?
Sir, ribs, sir. Transverse process of the
Yes. The cervical transverse
ribs,
process is looking downwards, and
yes,
the thoracic transverse process looking up. So if the rib is starting from a transverse process which is looking down, that is suggestive of cervical rib, and a rib which arises from the cervical process, the transverse process which is going up,
yes,
it is a
thoracic.
thoracic rib. Okay,
Yes.
then if you took an X-ray, there's suspicious there's a rib, but it's not convincing. Then what will you do?
I will go for a CT.
Okay, CT or MRI? Which you prefer?
MRI is more better because of to rule out fibrous band and other things.
Yes. If you're looking at, if your purpose is to detect a cervical rib or any compression
Yes.
by a soft tissue, MRI is a better option. And
Yes,
that
sir.
gives a better identification of the nerves also. The CT will not identify the nerves.
Okay.
So patient has severe pain. If you are investigating for the pain, I prefer an MRI than a CT. CT I prefer if I go for a CT angiogram. Okay. Then, so MRI shows a doubtful band. Then,
I will go for MRI, the Doppler scan, sir.
For what?
To identify the level of occlusion, is there any thrombus or embolus present or not?
Okay. Then you ask the radiologist to do a Doppler. What all things will you expect from him?
It's whether it is a monophasic, biphasic, or triphasic flow.
Okay.
Condition of the vessel wall, the diameter of the vessel wall.
Okay. I'll be asking the Doppler to see whether there's an occlusion. As Prakash said, there is a post-node dilatation, any aneurysm present, and whether there's any thrombus or embolism present distally, and what's the extent of it. Okay. These things have to be assessed.
Okay.
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 Then,
Yes, sir.
then what will you do?
Any thrombus is there?
You straight away operate. You done a Doppler, you done MRI, you done a
Yes.
X-ray neck.
Yes.
Straight away you operate.
No, sir. I will go for protein blood investigation, sir.
What all things you look for routine blood?
Complete blood count for
For what?
HB status and platelet count. Sir.
HB status, what significance?
Any polycythemia whereas
Okay.
hypercoagulable state.
Yes, particularly as Prakash said, there is a history of consanguinities there. Polycythemia is a possibility. Yes, okay, then.
The platelet count, sir. Any thrombocytosis or present.
Okay, then. Anything else in that routine blood examination?
For RFT.
RFT for what? Routine blood examination. I'm saying first is testing on the routine blood examination. Anything? As I said, the initial part, there's a possibility of arthritis. Okay.
Yes,
so in these patients, particularly upper limb involvement, you have to check the ESR, you have to look at the CRP.
Okay. Sir.
That's importance is two. One thing is to diagnose as arthritis or not. And if it is arthritis, the disease activity has to be assessed. If ESR and CRP is very high, that means this is quite active. You have to give medications to reduce the disease activity. Otherwise, if you put a bypass or angioplasty, it will get immediately occluded or leak. Leak also can happen. So the disease activity has to be controlled by proper medication, which will come later. So ESR CRP is mandatory before you're operating an upper limb vascular arterial disease. Okay.
Yes, yes.
Jailal sir, Prakash.
In this case, I would also suggest sickle cell evaluation.
Yes.
Because as you were telling me, it's a Buddha patient. So Buddha patients are notoriously prone for sickle cell disease.
Okay.
So that's another thing you need to rule out. And another thing I would like to do is to rule out tuberculosis, flare, because that's one of the possible suspected etiology in aortic arthritis actually. So you need to evaluate the patient for tuberculosis. In past in the history, I don't know whether you mentioned, but getting the patient evaluated for TB. That's a very important part of the workup actually, because basically one thing is you're not only looking at the etiology, and anything you want to do mostly will be done under GA. So in this patient, you're particularly interested to see whether the patient got an active tuberculosis going on. Okay, yeah. Okay.
For diagnosing, you initially thought it could be an atherosclerosis. So do you want to do any test on that also? When you are suspecting that it could be a possibility of atherosclerosis.
To look for lipid profile, sir.
What do you look for? poor lipid profile, you said there is no thyroid disease in this case. It is
Yes, sir.
hypothyroid disease.
So in hypothyroidism, there is a hyperlipidemia, obesity and hyperlipidemia.
You get the similar symptoms into the vessels in what kind of thyroid?
Hypothyroidism.
Hypothyroidism, yes, it can induce your atherosclerotic pattern. That is the difference. So you are saying you are looking for a thyroid mass in the neck, you are not able to see. So if that can rule out, there is thyroid is not producing this.
No, sir, I will go for thyroid function testing.
No, I am not asking on the function test alone, even for the clinical. So where do you get these obstruction features happens? What kind of thyroid?
Papillary CA and lateral apparent thyroid will compress the.
Retrosternal goiter.
Yes.
Or the retrosternal goiter. That is also when you say looking for other reasons. Now, what thoracic outlet syndrome when you are talking about, then other reasons for that also you must look for.
Okay.
So, thyroid, as you said, thyroid function test, when there is a hypothyroidism is there, that can also induce atherogenicity more. Now, renal lipid profile, all are normal. Renal function is also normal. For your patient, renal function is also normal. All the other parameters are within normal limit, no?
Okay, sir. Yes, normal only, sir.
Okay, then how you are going to go ahead?
I will go for a CT angiogram, sir.
For what reason?
To identify the level of lesion, if there is any thrombus or embolus is there or not.
You have done a CT?
Yes, sir.
What is your finding?
It shows there is a thrombus at the subclavian level, sir.
You have the picture.
Yes.
Because this is the picture, Prakash.
Father, I mean, it's a typical OT patient missing. And they have very bad. Literally, nothing is seen, isn't it?
Yes, sir.
Yes, Prakash, tell us, please. Proceed.
No collaterals also, no?
No collaterals.
No collaterals also.
You are not seeing any gangrenous features there.
Yes, sir. No gangrenous changes, sir.
What is the length of the thrombus?
Sir?
What is the size?
Length, size of the thrombus.
Sir, it's about 4 centimeter and about 4 centimeter length thrombus, sir. Completely occluding the subclavian artery.
If it's only 4 centimeter, there should be collateralization in the visualization, the distal, isn't it? It's completely like we are not able to see any axillary or radial, brachial bifurcation. Nothing is seen. So it looks like the whole artery is completely occluded by thrombus actually.
Okay.
What is the report? Can you read out the report if you have a report there?
Sir, no, sir, I don't have a report, sir. But it shows there is atherosclerosis thrombotic in the first and second part of the subclavian, about 4 centimeter length, sir, without any collaterals, any blood flow to the distal flow, sir.
Yeah.
The subclavian steal syndrome?
From the vertebral artery, from opposite side vertebral artery, the blood is directed towards the affected side vertebral artery to the second part of the subclavian.
Features patient will have?
Sir, patient will have a headache, blurring of vision, and sudden blackouts.
vertebrobasilar insufficiency patient may
Yes,
have.
sir.
So this patient, it seems the vertebral artery is also blocked, no?
Yes, sir.
So the brain will get the blood from the other opposite
Side.
opposite side. So what you are intending to do that for this?
I will plan for surgery, thrombectomy, sir.
That's a very, very important investigation. You've not mentioned in the list of investigation.
Sir, coagulation.
No, not coagulation. For a patient with suspected upper limb arterial disease, query, embolic, thrombotic, what is one, and not only from a diagnosis point of view, but also from a preoperative assessment point of view, one very important investigation is missing. And this community is notorious for having huge left ventricular clots and left atrial clots. So, did you get a echo done?
Yes, sir. Cardiology opinion and echo done, sir.
You didn't mention. You must mention. Because I tell you, I'm not exaggerating. I see these patients almost every day, Badiga patients, and when they present with ischemia, sometimes in the CT angio we find huge clots sitting on the arch of aorta,
Yes,
and in some cases actually we had to put the patient under bypass and get the clot out. So this patient, and we have noticed huge clots sitting in the left ventricle and left atrium. So that's one thing you must mention when this thing, because you're not mentioned the echo findings there.
Yes,
so if normal, that's fine, but you must mention in the list of investigation, echo is a must here.
Yes.
Okay. Yeah. So what is the, do you think this is acute chronic or acute on chronic? Because the patient seems to be having it for, you have mentioned the symptom
2
duration.
months.
So do you think it is acute or acute on chronic or chronic?
It's a chronic disorder, sir. 2 months duration. And spine also for 20 days, sir. More than 20 days.
20 days. Then anything else to suggest it's chronic?
There is no limb threatening ischemia or gangrenous changes.
Muscle wasting. Muscle wasting. That's again another pointer towards chronic. So it's all looking in favor of a chronic disorder. So what will be the next step?
I will go for a thrombectomy, sir.
3 months old duration, do you think thrombectomy will be possible?
Sir, only 4 centimeter of the 5 centimeter of the thrombus is there, sir. Can maybe go for a thrombectomy.
Usually it will thrombose within 6 hours actually. The longer the duration, thrombectomies don't work. That's the nature of thrombus. Okay. Yeah. Anything else? So anything else from Sri Kumar? Any other suggestion?
No, he's busy. These are sad on the phone. In this case, Prakash was taken over by the vascular department, and they intervened. And we lost the follow-up of the patient because I don't know what happened. Patient left or not. But they have done a thrombectomy or something, and we have to find more. We have to find out.
Thrombectomy, usually, these thrombectomies don't work. That's a problem. And the longer history, maybe when you do a thrombectomy, you will find there is a different consistency to the recent thrombus and the old thrombus. Maybe you may establish some status quo, but invariably the disease process makes it sure the thrombosis within no time, and the patient is back to square one. We have, especially as I was telling you, these patients are very, very notorious for thrombotic complications. You do a thrombectomy, you think it's working well, and next day morning you will find everything is back to square one. So I don't know. I think I'll ask Rajesh. He's my colleague only, so I'll find out what's up.
Professor Srikumar sir, this is the sir. You are muted, sir.
Okay. 5 minutes I was out. Yes, sir. Srinivasa, sir.
Sir, this was the patient's CT angiograph picture. The patient was taken over by the vascular department, and then we lost the follow-up of the patient, sir, because of.
So, Prabhu, can you read the CT angio?
You find out.
Can you read it?
Sir. Yes, sir.
Yeah, please.
It's a CT angiogram showing right bilateral upper limb and thoracic. It shows there is a occlusion in the left subclavian level. With this, there is no collateral formation and there is no distal flow in the left upper limb.
Okay. Then always, as I corrected it earlier also, always in these cases, you should explain the normal side.
Yes, sir.
Okay.
There is an yes, sir.
Yes. Read the first normal, right?
In right side, it's shows right side normal flow. There is no occlusion, no atherosclerosis, and flow up to the fingers, distal fingers also.
Fingers, you cannot see the finger.
Yes, sir. Distal up to radius.
Okay. Distal forearm is visible, fingers are not seen. This is not a good picture. Okay.
Yes.
If it's a good picture, that should show the up to tip of fingers. Then only angiogram is complete. Okay. Right side, say you have seen a normal vessel. Yes. What about left side?
Only first part of subclavian is there, sir. Other
and there is a single collateral is going.
Yes.
Okay, a weak collateral is going now. Okay.
Yes, sir.
So again, then with this, what is your diagnosis?
Occlusion at the subclavian level.
What type of occlusion it is? There is absolutely no collaterals. What type of occlusion it is?
Complete thrombotic occlusion.
No, it's acute or chronic or subacute.
It's a chronic occlusion.
No. Always in a chronic occlusion, there will be collaterals.
Okay.
Okay. Because patient have enough time to develop collaterals. So to say a chronic occlusion, there should be collaterals.
Okay, sir.
When there is absolute cutoff of an artery, that is more in favor of an acute occlusion.
Yes.
Okay.
Yes, sir.
Yes. So there is acute occlusion at the second part of subclavian artery. Okay.
Yes, sir.
There is no dye is seen either in the brachial, axillary, or radial or ulnar vessels.
Yes, sir.
Okay. Then what are the possibilities?
Probably thoracic outlet obstruction.
Yes. That's a possibility in this case. We cannot exclude because second part of subclavian is occluded. Yes. So that there may be a thoracic outlet occlusion there. Okay.
Yes.
Did you do echo in this patient?
Yes, sir. We done echo, sir, but it's normal only, sir.
It's normal only. Okay.
Yes, sir.
Then how will you proceed?
Acute. If it is acute, I will go for a thrombectomy, sir.
With this pathology, if you do thrombectomy, what happens immediately?
Sir,
so unless you correct the primary pathology and you feel straight away do thrombectomy, immediately that will thrombose.
Okay.
That'll produce more damage. Immediately the hand will go for gangrene. So that's one important message is in this picture, if there's it's a primary pathology, an occluding lesion, always try to correct the lesion, then only you go for, on the same sitting itself, you can go for a embolectomy or thrombectomy, whatever it is.
Okay.
Okay. Never try to do a embolectomy or thrombectomy without correcting the primary lesion. You will be in more trouble. Patient may lose the limb. Ultimately, blame will be on your head.
Yes.
So we should be very careful about it. Okay.
Yes.
Will you do an ultrasound abdomen in this patient? If yes, for what reason? This patient has come with sudden thrombosis and sudden whatever. And I'll tell you, one of the main reasons you should look for any vascular patient is malignancy. Okay.
Okay.
Malignancy. I've had patients refer to me for thrombosis, and I've picked up lymphomas, stomach CA, renal cell CA, pancreatic CA, and so on. So any thrombotic patient, the workup will not be complete unless you look for malignancy. Okay. So basically, I do a simple chest X-ray, ultrasound abdomen, and do some tumor markers. So in this patient, actually, having said that, I've seen a patient who was referred to me for upper limb ischemia, and I picked up ovarian tumor. So any patient who comes to you with thrombosis, you must have this thought running in the back of your mind whether this patient has got an underlying malignancy. We have seen patients with the hematopoietic malignancy, like acute leukemias, chronic leukemias. Of course, polycythemia vera per se, it's a prothrombotic condition. So any malignancy, you must think in the back of the mind whether this particular patient, especially the 65-year-old patient, you must rule out malignancy. Keep that in the back of the mind. It's a very, very important take-home message. Okay.
Again, I said about the importance of ESR. If the ESR is raised, you have to think about these possibilities also. Some malignancy also. Okay. It's a lady is having features of a thoracic outlet syndrome, occlusion at the second part of subclavian. Then what will you do for this patient? You have done all workup. Everything else is negative. Will you operate this lady or not?
Yeah,
you will operate because patient is symptomatic.
Yes,
Okay. She's in 60s, not too old aged. Patient is symptomatic, upper limb is significant. You have to operate.
Yes.
How will you operate? What's the approach and what's the procedure?
Embolectomy through the brachial artery approach.
I specifically told you, don't go for embolectomy without correcting the primary pathology. Here, I suspect thoracic outlet obstruction. How will you correct it? Fast.
Identify the causes of the thoracic outlet obstruction.
You are not entertaining the possibility. Are you sure? Okay, I'll go with you. You are not entertaining thoracic outlet syndrome. Then what will you do? You have your possibilities axillary artery thrombosis. Okay.
Yes.
Then what will you do?
I will start at anticoagulant and
simply anticoagulant. Only anticoagulant.
antiplatelets.
Antiplatelets. Patient is not improving. You started rivaroxaban, you started warfarin, you started cospirine, clopidogrel. Patient is not improving. Patient is symptomatic. Is it a bypass possible?
Yes, sir.
How? Do you have a distal normal vessel?
There's no distal normal vessel, sir. Yes.
Yes, so a bypass is not technically possible.
Yes, sir.
Because angiogram doesn't demonstrate a distal normal vessel.
Yes.
Then?
The prosthetic, the graft. Sir.
So it's whatever the graft, as a vein or prosthetic, you have to place distal at some point. And
Yes,
there
sir.
should be a normal vessel beyond that point to take the blood to the distal point. There is no vessel seen anywhere.
Yes, sir.
There is no brachial artery, there is no radial artery or ulnar artery.
Yes.
Then this bypass is in this CT angiogram, a bypass is not possible. Prakash, what's your comment?
Yeah, this patient has to be treated conservatively, and I think we have to take things as they come. That's all. She's not going to do well in the long term.
Sir, we have Professor Yashwant Lamture also. He's from Savangi, from Tata Mega Institute of Medical Sciences. He has some issues in joining us. I think sir is here. Dr. Yashwant Lamture, are you with us, sir? I'm not sure. He has messaged me that his connectivity is poor. Maybe if he's available, then we can take his comments. Otherwise, Prakash, sir, you please carry. I'm sorry for interrupting you.
No problem. Yeah, I think this patient, she's not a candidate for thrombectomy. She's not a candidate for bypass. So we have very limited options. And actually, there is a separate, in all vascular surgery conferences, we have a thing involved for, non-reconstructible disease, what we do. So I think she will probably come into that category. And, we have various options like putting them on long-term anticoagulation and using prostaglandins. Upper limb sympathectomy, maybe, these are, and another problem is this patient lives in Ooty and she's going to have a lot of problems during winter months. So, as I was telling you, long term, this patient may not do well. Slowly, she may start developing finger gangrene and so on. I'll be very interested to see what the vascular surgery department have done. And looking at the long history, I don't think any thrombectomy is feasible in this patient. I don't think whatever thrombectomy you do, there'll be a flow for about 5 minutes. I just finished the case and the same thing happened. I did a thrombectomy and within 5 minutes, the whole thing blocked up. So it's a very thankless job. The quicker you come, the thrombus is amenable for thrombectomy. The longer you delay, the thrombus becomes a chronic thrombus and it's not an ideal case for thrombectomy. So this case is not going to have any surgical options. So I think it's going to be mainly a medical management. So controlling, other risk factors and controlling if the patient is polycythemic, keeping the hemoglobin low. And, the patient can, this patient is ideal for long-term oral anticoagulation. And now we have a lot of new anticoagulants available. So she'll definitely benefit from them. And I think that's how we have to go for this patient. This patient is not going to be a surgical candidate at all.
Thank you, sir. I could see Professor Kumkum Singh, Professor Tangamani, sir, Professor Shilpa, madam. Any other experienced or comments from all our senior professors before we move on to the next patient, madam? Jailal, sir.
As I was telling, this is a Ooty patient, and because I live in Coimbatore, which is the first stop for these Ooty patients, I've seen them. The 15 years I've been seeing them, and in a male patient, of course, they all smoke. Most of the Ooty patients smoke. But this lady, fortunately, is not a smoker. So at least that cuts around one risk factor. But as I was telling you, there are other factors operating outside, genetic factors and so on. So I think those things basically not under your control. So this patient is ideal candidate for long-term oral anticoagulation. And I think the collaterals should slowly pick up and hopefully she'll do well. I think that's how we have to go about it.
This possibility of some reason must be there. I still think in terms of thoracic outlet syndrome, maybe the possibility. So,
yeah. See, the thing is, even if you do all possible tests, he hasn't mentioned the list of possible coagulation prothrombotic workup we can do. In about 40 to 50%, we may not pick up anything. You do protein C deficiency, protein S deficiency, factor V Leiden, and all. You go through all this thing. In this particular group of patients, actually, sometimes it's very difficult to pick up anything the same. So ultimately, you again come to the same endpoint. You put the patient on long-term oral anticoagulant. That's all. And these patients, steroids may help. That's another thing. And I do put them on steroids, at least on a short-term basis, actually.
I'll find out the details and get back to you, Prakash.
Okay. So, Prabhu, the message is, as Prakash said, the message is very clear. If you have to do bypass or angioplasty, there should be a distal vessel, distal normal vessel. That's mandatory. If it's not there, you cannot put a bypass or angioplasty. Yes. Okay. Here, as Prakash said, you have to exclude a malignancy. You have to, but still, my clinical possibilities is a thoracic outlet syndrome. So we need a MRI of the area to see whether something is occluding it. If it's excluding it, I'll do a release of thoracic outlet syndrome with or without, depending on the status, with or without a embolectomy or thrombectomy. If there is a subclavian artery aneurysm, I'll repair it, or I will resect it and put a graft there, and I will release that thoracic outlet, then see how she's improving or not. With a proper consent that there is a chance of losing the limb after surgery also. So that's my clear.
Thank you very much, sir. Do you have any questions, Ma, to ask the faculty? Do you have any doubts or any questions to be asked to the faculty?
Yes, sir.
Okay. Thank you very much. With the permission of the faculty, now we move on to the second case. Can you please unshare your screen now?
Yes, sir.
Jacob, please introduce yourself and start your presentation.
Yes.
Faculty, please take over.
Good evening, respected faculties. My topic is case presentation on lower limb peripheral arterial disease. I'm Jacob Liasani from Coimbatore Medical College, doing my final year postgraduate. I'm doing this. I would like to thank my chief and guide, Professor Dr. T. Srinivasan, and my head of the department, Professor Dr. V. Lakshminarayani, and my assistant professors, Dr. J. Lakshmi ma'am, Dr. Balasubramanian sir, and Dr. Vijay Shankar sir. Coming to the history of the patient, a 68-year-old male patient residing in at Coimbatore, laborer by profession, coming from low socioeconomic class, presented to the surgical OPD with chief complaints of pain in the left lower limb for the past 1 month and blackening of the left foot for the past 2 weeks. Patient was relatively asymptomatic before 1 month, after which he developed intermittent claudication cramping type of pain in the left lower limb, thigh, most commonly the thigh and calf region while walking, and made it to take rest. Initially, he was able to walk for 500 to 800 meters with the help of a walker, but he had to take rest in between. But now he can walk only up to 500 meters since last month because of the claudication pain. The blackening has further progressed, involving the second toe and the great toe and extending slightly up to the forefoot, dorsum of the foot. There is no history of any trauma to the limb, no edema of the limbs or dilated veins. There is no history of any weakness of the limbs, no history of any transient blackouts or blurring of vision. There are no history of any chest pain or postprandial abdominal pains. There is no history of any impotence or any upper limb pain. Patient is a known case of diabetes mellitus and systemic hypertension for the past 10 years, and he is on regular medications. Patient gives a history of having similar complaints of claudication, crampy pain, and blackish discoloration of the right foot and lower leg for a duration of 3 months. And he was diagnosed with right lower limb PVD 6 years back, for which the patient had underwent right aboni amputation in a private hospital. And it's not a known case of any stroke, CAD, or hyperlipidemia. Family history, there is no history of any similar complaints in any of the family members. Personal history, patient consumes mixed diet. The bowel and bladder habits are unaltered. The normal sleep habits. Patient is a chronic BD smoker since the age of 20 years, and he has been smoking about 12 BDs per day. Smoking index is 576. But the patient had gave a history of continuing to smoke 2 years even after amputation of his right lower limb. But in this last
Your range is connectivity some problem.
Your voice is breaking up.
You can switch on the video and continue. Then after that, we can switch on the video.
Right aboni amputation.
Jacob, switch off your video and start.
After that, we can switch on the video.
He's not listening.
Maybe he's not hearing.
Right.
Yes, very poor connectivity.
Hello, sir.
Yes, please.
Jacob, you could switch off your video and start presenting the.
Yes, sir. Yes. Sir, shall I start from the beginning?
No need. You can continue that. Yes, that's it. Okay.
Summary: a 68-year-old patient came with complaints of pain in the left lower limb, sir, for the past 1 month, along with blackening of the left foot for 2 weeks. A patient who is a known case of diabetes and systemic hypertension for the past 10 years and is on regular medications. Patient had undergone right aboni amputation as he was diagnosed with right PVD for 6 years back, sir. He's also a chronic smoker since the age of 20 years.
Go back to slide. Second slide. Okay. What is his pain-free walking distance now?
Sir, along with the walker, he's able to walk like 400 to 500 meters. He's having only one leg, sir. He's having difficulty walking.
Yes, already amputation on the opposite limb, no?
Yes, sir. On the right side, he has undergone amputation, sir. With the help of walker, only he's able to walk.
So right side amputated, you tell when was it done? How long did he have that visit? And after how many days did he develop this one? Is it important or not?
Yes, sir. 6 years back, he was diagnosed, sir, as he had complaints of claudication pain and blackish discoloration, sir, for a duration of 3 months at that time, sir. Following which he had undergone surgery, sir, right lower limb, right AK amputation, sir. And so-
6 years later, he developed on the other
yes,
limb.
sir.
He was still
Yes, sir.
smoking.
Yes, sir. After amputation, for 2 years he was smoking, sir. The remaining 4 years, he said he stopped, sir. He had stopped.
What's the concept about a smoking index? Any idea?
Sir, it is the number of cigarettes that has been smoked in a day into the duration of smoking, sir, per year.
What is a cutoff number to say somebody is a low volume smoker, high volume smoker?
Less than 400
per day. Less than 400 is supposed to be a non-smoker.
Yes, sir.
Okay. If per day smoking is less than 20, that means a low volume smoker, or more than 20 is a high volume heavy smoker.
Okay.
And if the number is less than 400, he has to be considered as a non-smoker. If number is more than 400, if that smoking index is more than 400, you have to consider him as a smoker.
So is there any difference in the cigarette he is using, whether he has a BD or the...
Yes, sir. He was using BD, sir. BDs. 12 BDs, sir.
I'm asking Srikumar, sir, in fact. Whether do we say the smoke index, maybe somebody says BD, that the same thing gets applied, or only filter cigarette also the same thing is applied?
No, yes, sir. It's a very good question, but it's not proven. But the people says the BD has more affinity to arteries than the cigarettes. Particularly, filtered cigarettes have less affinity towards arteries because less nicotine is reaching the system. So if somebody is taking more BDs, he is a more risk of developing arterial disease. That is, I don't know, it's proven or not. I haven't read any literature or article on that. But it is well discussed in many forums, sir.
Yes.
So BD smoking is more dangerous for an artery than a cigarette. Again, the cigarette, a filter cigarette, has less risk than the comparing a regular cigarette. That's what.
But the same index calculation can be applied for all.
Yes, sir. Okay, Jacob.
Yes, sir.
Yes. Next. Why he is under a AK amputation?
Sir, he had complaints of claudication pain, sir, with blackish discoloration extending up to knee, sir.
So not
6 years back, sir.
Not treated that time.
Sir, it was treated, sir, but all the details the patient didn't have. So 6 years back, patient didn't have any details. As per patient's history, this was only available.
Right now, the patient is having rest pain?
No, sir, no rest pain, sir. No rest pain, sir.
How can he not have rest pain? The patient is having gangrene, toes, forefoot, and all those things.
Sir,
he must have rest pain. I find it highly unlikely the patient doesn't have rest pain. You said in the history has got necrotic toes. How can he not have rest pain?
Can the patient have the both at the same time?
Sir?
Can a patient has both claudication pain and rest pain?
Sir, when the
ischemic
changes, yes.
Both are entirely a different mechanism you are getting. The claudication pain you are going to get at the calf muscles, and it is due to the vascular only. That is for the neural involvement.
Yes, sir. Rest pain.
You will have that just because he is having claudication pain, don't think that that patient will not have a rest pain. The rest pain with the farthest nerve you can have, in the foot he can still have. Especially your patient is having a gangrene, say the gangrene is spreading, but still if you think that patient is not having rest pain, maybe the mind you are not asking that in a proper way.
Can you explain? Okay, we accept your answer. There is no rest pain in this patient with such a critical limb. Can you say any reason for that? Can you explain that?
Sir, it's a chronic limb ischemia.
Chronic limb ischemia with a critical limb, such a massive ulcer or a massive necrosis, patient are definitely rest pain. But patient is not complaints of rest pain. Any reason? This patient, if we are right, the patient might have severe neuropathy. Then that may mask the rest pain. Definitely the patient will have rest pain, but if there's severe neuropathy, there may be possibility of a patient not experiencing the rest pain. That's all. Patients have rest pain. Okay. Next slide, please.
Can you define rest pain, by the way? When you say rest pain, what is the definition of rest pain?
Sir, the pain that are seen mostly in the foot, sir, due to the ischemic changes of the nerves of the foot, sir.
No. You must read up the definition of rest pain. Rest pain is pain which keeps the patient awake at night for at least 3 nights consecutively, and it's not only lower limb; it can happen upper limb also. So rest pain is pain which keeps the patient awake at night. Basically, at the daytime they're not. They have other distractions, so they can do other things. But night, when everything is quiet, the patient, that's when the pain is very, very severe, and it's at rest, obviously. No, okay, yeah, yeah, carry on.
So coming to the general examination, sir, examine the patient in proper light with exposure and informed consent, sir. Patient is conscious, cooperative, and oriented to time, place, and person. His average build fairly nourished, sir. The height of the patient is 165 centimeters, weight of about 65 kilograms, and a BMI of 23.9 kilogram per meter square, sir. Patient has no pallor, icterus, cyanosis, clubbing, or any lymphadenopathy. Vitals, patient is afebrile, sir. Pulse rate of about 88 per minute in the right radial artery with a regular rhythm, good volume, normal amplitude, with no radial artery wall thickening, sir. No radial delay or radiofemoral delay, sir. The blood pressure is 110/70 mmHg in the right brachial artery and 110/80 mmHg in the left brachial artery with patient in the sitting position, sir. Respiratory rate is 16 per minute, sir, and the RBS that was measured at that time was 112 milligram per minute deciliter. Local examination, patient is examined in the sitting, standing, and supine positions with both the lower limbs exposed from the anterior superior leg spine to the tip of the toes on the left side and up to the AK amputation stump on the right side. Coming to the inspection of the left lower limb, the attitude of the limb was normal, sir. Skin was thin and shiny with loss of subcutaneous fat and hair. Toes, the toenails were brittle with transverse ridges seen over the nails. Blackening was present over the great toe and second toe, extending slightly into the dorsum of the foot. There was no line of demarcation. Active toe and ankle movements were present. No deformity or loss of toes. No muscle wasting in the thigh, calf, or foot. Coming to the inspection of the right lower limb, the patient had a post bony amputation stump, sir, which was healthy. The scar was of 795 centimeters was present, sir. No gangrenous changes. Active hip movements present, sir. Coming to the palpation, sir, the left lower limb was having comparatively lower temperature when compared to the right lower limb, sir. Dry gangrenous changes were present over the left great toe and second toe, sir. There were loss of sensation present over the great toe and second toe. Hyperesthesia was present over the dorsum of the left foot, sir. Capillary filling time was 6 seconds. Venous refilling time was slightly delayed, sir. There were no crepitus or pitting edema over the adjacent skin. The movement of the toes, ankle, knee, and hip joint were normal, sir. There were no inguinal lymphadenopathy. Palpation of the vessels. The dorsalis pedis was not assessed on the right side, but it was absent on the left side. And anterior tibial not assessed on the right side, absent on the left side. Posterior tibial popliteal artery not assessed on the right side, absent on the left side. So femoral artery absent on both sides. The radial artery, ulnar artery, brachial artery, common carotid artery, superficial temporal artery were palpable in both sides. Upper limb and head, the bilateral upper limb pulsations are normal, sir, and carotid pulsations are normal, sir. On auscultation, there was no Breuer hurt, sir. Abdominal examination, it was soft, non-tender, no dilated veins or visible pulsations, sir. There was no palpable mass. On respiratory system examination, bilateral laryngeal was normal, sir, no abdominal sounds. The S1 and S2 was present, sir, and there were no murmurs. And central nervous system examination, there's no sensory or motor deficits. 68-year-old chronic smoker presented to the OPD with complaints of pain in the left lower limb since 1 month and blackening in the left foot since 2 weeks. Patient underwent right abdomen amputation 6 years back for the right lower limb PVD. Sir. Patient is a known case of diabetes mellitus and hypertension. Sir. Patient was a chronic smoker. On examination, dry gangrene was present over the left plate and second toe. Changes of chronic ischemia is present. Sir. Left lower limb pulsations from the popliteal artery were not there. From the femoral artery were not there.
Jacob,
Yes, sir.
Over.
Yes, sir.
How to check the muscle wasting in this patient?
Sir,
You said there is no muscle wasting. Compared to where?
Comparing the thigh circumference of the.
But you said the
both
lower
limbs,
limb, by lower limb also there is no wasting. It's an amputee.
Yes, sir. Up to thigh only he had, sir. So only thigh I was able to.
But you, this in the your presentation, you said that lower limb there is no pulsation, wasting even the lower part also. Okay.
The patient has definitely muscle wasting because a few reasons. One is, of course, he's got ischemia. Second is there is, because you said an amputation on the right side, the challenge to the muscles is not there. So it's an underused muscle group. This thing definitely wasting will be there. The reason why you think there is no wasting, there is no comparison from to be made on the right side because everything is missing. There is definitely muscle wasting there actually. It looks wasted actually. Like I was waiting for. To ask this question, Sigma preempted me.
Sorry. So the picture shows there's definite wasting.
Yeah.
There is definite features of chronic ischemia also. Can you show the picture of the limb? Yes, see it. Is that the appearance of a working class man with his lower limb, this calf muscles? It's definitely wasted. There is wasting. Only things you cannot say there's no wasting. Okay.
Gangrene, but and you said some hyperesthesia. Where was the hyperesthesia? Is there?
For the dorsum of the foot, sir, little bit near that gangrenous area. Not the entire part, sir, near that gangrenous area.
So what is line of demarcation? You are able to see?
No, sir, no clear-cut line of demarcation. It is not found.
Is it a critical limb?
No, sir.
Is it a critical limb or not?
No, sir. According to the criteria, he had no rest pain, sir, for more than 2 weeks. He has no.
What are the criteria for critical limb?
Sir, he should have recurring rest pains for more than 2 weeks, sir.
Okay.
The angle systolic BP should be less than 50 mmHg, or toe systolic BP should be less than 30 mmHg.
Did you check it?
Sir, the angle I checked, sir, but the toe I couldn't check, sir.
Angle how much?
Sir, it was less than 50.
Less than 50.
Yes, sir.
Less than 40. That's a one feature of a critical limb.
Yes, sir.
Okay. Toe pressure, if it's checked, what's the cutoff value?
Sir, less than 30 mmHg.
30. Okay. It is 40 itself in that lower limb itself, ankle. So then, any other criteria?
Sir, ankle brachial pressure index should be less than 0.3.
Yes. How much? 0.3.
0.5, less than 0.5. Sir.
How much it is here?
Sir, it is 0.5 only, sir. It is 0.5.
0.5. What's the upper limb pressure?
Sir, it is 110/80, sir.
110/80. So this is by 40 by 110. How much it comes?
Sir, 110 by 40 by 110.
How much it comes?
Sir, 0.4, sir. 0.4.
0.4.
0.36, sir. 0.4.
Okay. So is it critical? Is it critical?
Yes, sir. Angle brachial pressure index is less, sir. Yes, it's critical.
Yes. So angle pressure is less than 40. ABP is less than 0.4.
Yes, sir.
So is it not a critical limb?
Yes, sir.
Yes. Out of the 5 criteria, two are positive here.
Yes,
how will you assess ABPI?
Sir, we have to check the blood pressure of both the upper limbs, sir, and we have to check the blood pressure of the lower limb, sir. We have to
lower limb which pressure?
Sir, the ankle pressure.
Which angle pressure?
Sir, the pressure from the anterior tibial or posterior tibial arteries.
Which one will you take? Anterior tibial is 40 and posterior tibial is 45. Which one will you take? You
And
check the
please.
anti-tibial is 40 and posterior is 45. Which one will take?
And anterior tibial.
Anti-tibial. And the upper limb right side is 130 and left side is 136.
We'll take the maximum. Sorry, sir. We have to take the maximum systolic BP. After comparing, you have to check the maximum systolic BP.
Yeah, you check the maximum blood pressure of the upper limb, either upper limb, and the maximum pressure in the lower limb.
Yes, sir.
That has to be checked.
Yes, sir.
Okay. Why you take the maximum pressure in the upper limb rather than the corresponding side? You are assessing the right side, this patient is you are assessing the left lower limb. So why not take for left upper limb alone and compare it? In fact, what is the index pressure? You check the upper limb pressures, and in fact, what is the index pressure you are representing? Ideally, you are checking the cardiac pressure. Okay, that is why you take both upper limbs and you take the cardiac pressure, which is maybe the highest upper limb pressure. We are assuming that is highest upper limb pressure. So you are comparing that pressure to the angle pressure, highest angle pressure.
Yes.
Okay.
Yes.
So this is a critical limb. Do you have a erection problem? This patient has erection?
No, sir. No history of any impotence.
No,
No history of any erectile dysfunctions.
No, he has erection now.
Ah, yes, sir. Yes.
Okay, fine. Okay. Yes.
But left side, opposite side also, both the sides femoral artery is not palpable.
Yes, sir. Both the sides femoral artery not palpable.
So he has any symptoms on the left side?
No, sir. No symptoms on the left side, right side. No symptoms on the right side. Sir. The right side is perfect.
One question I wanted to ask, but Mr. When is ankle brachial index not reliable? Because you're comparing ankle with brachial index. So when it is not reliable?
So in case of rate limiting arterial diseases.
Especially in this patient when he has a long duration of the diabetes.
You took
Yes,
the
sir.
ABPI,
Yes, sir. You'll have calcifications of the vessel wall, sir. And,
if that is so, what will you do? You check the RBAPS is 1.4. Then what will you do?
Could you measure toe pressure?
Yes.
no, sir.
You have to measure the toe pressure, then compare, because by principle, the foot vessels never calcifies, or rare possibility is very rare. Did you check the history of the AK amputation? What's the primary healing or secondary healing or any delay healing problems?
Yes, sir. Delayed healing was there for the patient.
So, how will you proceed in this patient?
So, first, we'll take the routine investigation, sir. Then we'll go for a basic
What
duplex scan.
Routine, you cannot say what is routine.
Coagulation profile.
Routine in Trivandrum is not a routine in Chennai, or a routine Apollo Hospital, not a routine in Trivandrum Medical College. You cannot say routine.
CBC coagulation profile, sir. Since he's a diabetic, RBS, then the lipid profile we have to check, sir.
What significance of doing an RBS in this patient?
It's a diabetic.
Okay, diabetes. You have done an RBS 163. What's the importance of it? Do it give any information to you?
Uncontrolled diabetes.
Okay, this patient, the RBS is 84. Does it exclude diabetes? So a patient coming for surgery with a long history of diabetes, what's the rationale of doing an RBS?
To know whether it's diabetic control or not.
This patient, in a routine, you asked the sister to do it. They said it is 84. Is it significant? Or will you say patient is not diabetic? So in such surgical patient, better go for HbA1c or FBS. It's comparable. Simply an RBS, just coming to OPD, patient might have taken food immediately, or patient might have taken food 24 hours before that, 12 hours before that. He might have done a heavy exercise. He might have done after walking. So that is not at all reliable. When you're doing a surgical workup, it should be a comparable. And ideally, either a fasting blood sugar or a properly conducted postprandial sugar, or you go for HbA1c. A simple RBS in this patient doesn't give any significance at all.
Yes.
Yes. Then CBC, you are doing a CBC. What's the importance of it?
So we see the counts of the patients, whether it is infected patients or sepsis.
Is it patient septic?
It doesn't. No, sir.
Patient is lying in front of you. It doesn't have any
No, sir.
sepsis. Yes. Anything else?
So we have to check for the coagulation profile and
before that, CBC.
CBC.
Yes.
Oh, sir.
Its HB is 20. Is it significant? Jacob, this patient is 20. Yes. That is to be excluded first. Okay. When you're doing a CBC, you have to check HB is normal or not, ESR is normal or not, or if ESR is elevated, go for CRP also.
Yes.
In inflammatory markers present or not. Because it's old age, it may be atherosclerosis, but it can be some aortic arthritis also. It's also possible. Then you have to assess diabetes. Okay, diabetes patient, what all other investigation will you do? Patient is diabetic, your FBS is controlled, long-term diabetes, and hypertensive. What's the next investigation will you do?
Sir, we have to do a fundus examination.
What?
In a diabetic patient and hypertensive patient, sir.
Yeah. Investigation wise, what's the next investigation? This is a long-term diabetes, hypertensive, vascular disease. Which other organ will be assessed?
Sir, eyes will be assessed, sir. Fundus examination.
What's the significance of it?
There will be retinopathy.
Will you change the management policy? Or will you change their diagnostic criteria? Or will you change the prognosis of this limb? Two organs are very important in the case of peripheral vascular disease. Most of these patients are die of heart, and most of these patients, the outcome is decided by the kidneys. So you cannot treat a peripheral vascular disease without addressing these two organs. So these two organs needs equal or more attention. And none of these patients are going to die of due to infection in the forefoot. They are going to die of a coronary problem or a cardiac illness. And the type of management decided by, not by, there are a lot of factors, but one of the most important factors is the kidneys. Okay. So uncontrolled diabetes, uncontrolled hypertension, always there's a possibility of accelerated atherosclerosis. Both will accelerate atherosclerosis. He's a smoker, diabetic, hypertensive. All the three causes accelerated atherosclerosis. So you have to assess the heart, you have to assess the kidneys. So how will you assess the kidney?
RFT.
Yes, you have to do a serum creatinine and a GFR.
Yes.
Okay. Then.
Sir, then we go to the imaging study, sir.
Okay. What imaging you do?
Sir, we do initially we do a colored duplex scan, sir.
Before that, will you assess the heart?
Yes, sir. We have to do an echo, sir.
Yes. Echo, ECG, and a lipid profile.
Yes.
Okay.
Yes.
Yes. Then you cannot do a TMT because one limb is lost.
Yes.
If you're doubt, you go for a stress echo or whatever it is. Okay. Or thallium stress echo or some whatever it is. But basically, you have to do a lipid profile. You have to do an ECG and you have to do an echo test. Okay.
Yes. Yes.
Yes. Imaging, what imaging will you do first?
A duplex scan of the lower limbs, the left lower limb.
Okay.
To assess the vascularity of the left lower limbs.
Yes. If you're asking for a duplex, what all things will you ask for? Your radiologist friend is waiting for you. He's asking what to do or what all the points you want to know.
Whether the flow is normal, sir. Whether it is triphasic, biphasic, or monophasic, sir.
Okay.
Whether the flow is adequate in all the vessels, sir, of the lower limb.
Okay.
Whether there is any
what is the triphasic, biphasic, monophasic? What's the reason for this? What are the three waves?
Sir, in triphasic, there are three waves, sir. The first wave is systolic, produced by the systolic, sir. Second dip is produced by the diastole, sir.
Yeah.
And the third trough is produced by the recoiling of the vessels.
Okay, arterial recoiling. Okay, fine. Okay, good. Then you have done. You look for the flow is triphasic, biphasic, or monophasic. Then
To see if any collaterals or any vessels are present.
Doppler will not tell you about the collaterals. It's very difficult
to know if there is any the compressibility of the veins. The veins are compressible.
For what?
To rule out any DVT. To rule out any venous causes.
Atherosclerosis will you anticipate any venous problem?
Yes,
Are you okay? Are you suspecting TAO in this patient? If it's TAO, there's possibility. There is a phlebitis.
Patient is more than 40 years, sir. Old age patients, sir.
Old age patients, okay. And femoral pulse is absent.
Yes.
Old age patient, femoral pulse is absent. Thus, two are against TAO. Okay. Before going to imagology, I go to other examiners. Jailal sir.
Yeah, yes, sir. Right, you can go ahead.
Prakash.
Yes.
Only thing, looking at this picture, I'm convinced that it is a dry gangrene. The second toe you said, no?
Yes, the second toe.
So how do you say it is a dry gangrene?
It is
I think it is swollen.
Having a shriveled and mummified look, sir.
Is it shriveled and mummified?
No, sir. It's starting to the starting stage, sir.
So you will, in anticipating, you put the title as a dry gangrene. No, exam, you don't, if you are not seeing the typical of a dry gangrene feature, then don't say, because this patient is already diabetic patient is also there. So then we are making this as a dry gangrene, then maybe the questions will be more on that, seeing that whether you are really differentiating. Go ahead.
Prakash.
Yeah, we can look at the images. Yeah. CT images.
So you have planned for a CT image, and the creatinine is 1.7. Jacob, how do you proceed?
Jacob, one word of advice. If we are looking at a patient with critical ischemia, there's really no point in going for a Doppler. Actually, because I'm a vascular surgeon and deal with the critical ischemia all the time. In all my experience, probably I would have asked for Doppler only 2 or 3 cases, because most of the patients who come to us, they come with critical ischemia. So in this case, strictly speaking, you don't require a Doppler. You straight away need a imaging roadmap of what what is the CT finding?
Jacob, before that, the patients, you are resident in the ward, the patient's creatinine is 1.7.
Yes, sir.
Will you do a straight away CT?
Sir, I will do an MRI angiogram.
It also requires.
Yes. Is it safe? MRI angiogram create 1.7. You are working in one of the best setup. You are working in the best setup.
Yes.
Patient is a VIP. Will you ask for MRI? Or you have any other choice?
In a renally compromised patient, what are the options? Because even MR contrast, it can produce nephrotoxicity. So
yes, delayed gadolinium-induced nephropathy is a well-known entity. Maybe you are safe in the immediate week, but after 3 months or 4 months, patient will come back with a nephropathy. You cannot exclude the possibility of nephropathy. It's a GIN is an established entity, so you cannot ask for an MR angiogram if the patient is educated with a compromised renal function. So two things. One is, if the 1.7 creatinine, can you prepare the patient for a CT angiogram? What are the options? On the other side, you have decided go immediately any other option to have a safe kidney. Two questions.
How much volume do they give in a CT angiogram? To take a CT angiogram, any idea? With the injector, pressure injector, how much do they give? So keep that in the back of the mind when you answer this question. Okay.
Yes.
So, okay,
Jacob,
because
there is no time, so I'll give the answer. So if the patient is a compromised kidney, if the creatinine is 1.7, I will admit the patient. I will hydrate the patient very well. I'll wait for 2 days. I'll give NSAT 600 milligram 3 times a day. Then if there is any infection, I will treat the infection. Then I'll check again the serum creatinine. If it comes back to normal, I'll take the patient for the CT angiogram, provided there is good intra-op hydration present, followed by good post-op hydration. And I'll prefer a diluted kidney-friendly dyes. Okay. And again, I want the patient, there's a possibility of a post-procedure dialysis also. With these precautions, if the creatinine values are coming down to normal, after 2 days or 3 days of hydration, then you can go for CT angiogram. Okay.
Yes,
otherwise not. So these things are very important. And if it is not possible, if it's not coming down, or the facilities are very good, you can go for a CO2 angiogram. That is a safe entity. It will not affect the kidney. Carbon dioxide angiogram. Okay.
Yeah. The other option is a non-contrast, what you call MRI. That option is there, but it needs special software. So not all centers will be having it. So keep that in the background. But the problem is when you compare it with the CT pictures or a DSA, the pictures are not that good. So that's the only limitation. Okay. And the volume you give for a CT angio is almost like 150 ml. So obviously, the other option will be to go for a low dose digital subtraction angiogram, because that's this thing. But when you have an aortic disease, sometimes the pictures may not be good. So that's one of the problem when you go for a DSA. This thing, and again, the access needs to be through radial or brachial. Okay. Yeah.
Okay. Can you read the CT angiogram?
There's a CT angiogram of the patient, sir, taken from abdominal aorta to bilateral lower limb, sir, extending up to the.
Is it a complete angiogram or a good angiogram?
The toes are not.
Yes, the toes are not described. Otherwise, it's from the kidneys. It is going up to down. Okay, it's almost a good verse. But if it shows the toes, then it's a perfect angiogram. Okay, then read this.
Sir, it's showing there is no contrast of specification below the in the common iliac arteries, external iliac arteries, on both the sides. Collaterals are present.
Common iliac artery, left side common iliac artery is seen very well.
Sorry, sir. Left side is seen, right side is not seen. That means.
Yeah. Okay.
Collaterals are present in the thighs, sir, and in the legs.
Okay, that's there. Okay, then.
Popliteal artery is not fully visualized, sir. There's no opacification between femoral artery and popliteal artery, sir. There's a gap.
Okay. Then. Bifurcation.
The bifurcation is not clearly visualized.
Which all cells you have seen? What is the first branch? What's the first branch trifurcation? What are the components of trifurcation? Jacob, can you discuss the trifurcation? Trifurcation by 3 vessels. What are 3 vessels?
Yes, sir.
What are 3 vessels there? Below knee, 3 branches.
Sir,
major branches.
Anterior tibial, posterior tibial, peroneal.
Peroneal. What's the first one?
The anterior tibial.
Yes. Anterior tibial is the first one. And how is it?
Sir, anterior tibial, it's showing opacification, sir, but not fully till the down, sir.
Yes, there is only a 10 or 12 centimeter anterior tibial is there. After that, there is no vessel seen. Okay.
Yes.
Then positibial. Tibial trunk is normal.
Yes,
the positibial is. What are the positibial?
Posterior tibial is also showing only opacification only up to the upper calf region, sir, beyond which it's not clearly.
Okay, done. Perennial.
Sir,
Perennial is almost going down. Okay, perennial is almost
Yes,
going down. Yes, okay. So the patient is, so with the CT angiogram, patient is having a primarily there is occlusion of the external iliac artery, then the femoral artery. Okay.
Yes, sir.
Okay. What will do for this patient? Will you intervene this patient?
Sir, and CT, there is also in the CT scan report as given, sir, as infrarenal abdominal also shows partial occlusion, sir.
Okay, there will be, see, atherosclerosis is a generalized disease. It can happen from head to foot. Head to, yes. All vessels are involved. You will not get a normal vessel in this patient, such a smoker, diabetic, hypertension. There will be disease everywhere. We are treating only the pathologically affected vessels only. Okay. When there is severe obstruction, flow limiting disease, then that we will treat that part. Okay. Here there is 100% occlusion at external iliac artery, then the femoral artery. Okay.
Yes.
So how will you treat this patient or not?
We can try a bypass. Yeah.
Why you go for a bypass?
And distal vessel is patent. Distally vessel is visible.
Why do you go for angioplasty?
Yes, sir, we can go for angioplasty also, sir.
So which one you opt, this patient?
So mostly in the iliofemoral region, percutaneous transfemoral angioplasty is preferred.
Then what's the rationale for selecting these two, angioplasty or bypass? What's the factor which you help you to decide?
Yeah.
What is do you have any classification or grading system which you say this is ideal for angioplasty or ideal for bypass?
Task.
Yes, absolutely. Very good. What is task?
Sir, transatlantic inter-society consensus.
Yes, it's a transatlantic society consensus between the vascular and the radiologists. They have decided, they have made a consensus formula.
Yes, sir.
So what are the essential components of task? 1, 2, 3. Okay, it's not up to your level, but essentially you are looking at the length of the lesion, site of the lesion, and the grade of the lesion. If it's 100%, it's not, is this occlusion or stenosis, or length of the lesion and where is the lesion. Okay, these three are the factors which will help you decide. If the length is too much, so more than 10 centimeter, 50 centimeter, you go for a bypass because you cannot do angioplasty. If there is multiple lesions also, you can go for a bypass. If there is stenosis only, you go for a angioplasty. Okay, just remember, task will help you to decide whether angioplasty or bypass, and task is looking at the length of the lesion, the grade of the lesion, and the site of the lesion. Okay, that's only up to your level. That's not required. Okay.
Yes.
Prakash.
Yeah, I'm following. Yeah, this patient, do you think is suitable for angioplasty? I don't think so. So, what are the other options here? Because we do have some things called the subintimal and all, but I think that goes into MCHC again. This thing, but I think you can just at
MS level, this is a bypass condition.
Bypass, but okay.
Yeah.
For real, it's a bypass operation. Don't think about it. It's a long lesion, more than 15-20 centimeters long. And you have a normal, almost a distal vessel is also there. Distally, there should be at least 10 centimeters vessel to do the bypass. That's also a must. Okay. Otherwise, the flow will not be maintained.
Yes.
Okay.
Yes.
So if you are doing a bypass, what conduit will you use this patient? What are the conduit options you have?
Sir, if it is a suprainguinal, the occlusion is in the suprainguinal level, sir, we use mostly a Dacron graft, sir.
Okay, Dacron or PTFE, whatever it is. Okay.
Then. It is in the infrainguinal part, sir. Infrainguinal occlusion, sir, we mostly use a reverse saphenous vein graft.
Why do you reverse it?
To prevent the backflow.
Why do you want to reverse it? You can straight away put it. You are taking it out. You're putting long incisions, taking it out and reverse it. Why you want to do it?
To prevent the backflow of the blood.
Why there's backflow? You mean the venous pressure is more than arterial pressure to produce backflow?
What is the purpose of reversing it? Or anything? Why do you want to reverse it? Anything to do with the valves?
Yes.
Yes, JLS give the tip. What's the peculiarity of these valves? What's the peculiarity of these valves?
There are one-way valves.
Yes, these valves permit only one-way flow.
One way, yes.
Okay,
yes.
They are unidirectional valves. So if you put it straight, the veins take blood from the leg to the heart. Okay, if you put it the same direction, then the blood cannot flow from the heart to the leg. Okay, the valve is obstructed. That is why you are reversing it. Okay,
yes.
Do you have any other option where reversing is not required? That's called in situ bypass. Okay, you have any other option to do an in situ bypass? What's the major problem of doing a reverse bypass?
So the patency won't be.
No. Patency is best the artery, the vein. The main problem is the size difference. If you take a distal vein and bring it to the proximal femoral artery, there's no size difference. And if when you take the proximal vein to a distal most artery, there's again a big vein with a small artery. This size discrepancy is the major issue when you're doing a reverse bypass, vein bypass. Okay.
Yes.
So this can be overcome by doing an in situ bypass where the proximal vein to the proximal artery and the distal vein distal artery. Then the problem is the valves. You have any option to avoid this problem? Just a single word, that's all. Don't go for the technical aspects.
With the harshness.
The valve is your problem. Then can you do something to destroy the valve?
Yes, sir. Harshness.
Okay, there are different valvulotomes, harshness valvulotomes, different valvulotomes available. You can use a valvulotome and you can destroy these valves. Once you destroy these valves, you can do an in situ bypass. Okay, then the size issue is not there.
Yes.
Okay. This patient doesn't have a saphenous vein. Still, you want to do a venous bypass. What are other options?
We can use short saphenous veins.
Short saphenous an option. Then
upper limb
yes, you can harvest the upper limb veins also. So
cephalic veins, upper limb cephalic veins.
Yeah, upper limb cephalic and upper limb, even basic vein you can take it out. Yeah, you can do it. Yes, Jailal sir.
Is better. That is a previous amputation is a indication for other limb going for any problem, and what is the percentage of the limb will have even if you are treating it re-occlusion or problem.
There is a high probability, sir, that the other limb also can go into occlusions.
Especially not this when we talk about the diabetic foot, there is a previous history of mutation that 5 years, another 50% people will definitely get the second disease.
Yes.
So this patient will be more prone for getting other areas of the risk also. So you have to continuously maintain, even after doing this, continuously you have to put the patient on the surveillance and the maintenance therapy.
Yes.
One important problem here, this patient is continue to smoke after a major amputation. And I'm sure after you do this bypass, he'll just keep quiet for a few days and then slowly they'll start smoking and come back, so that's going to be a main problem treating these patients. However, whatever advice you give till you get till they get the surgery done, they'll promise anything. But just wait 6 months, then he'll start smoking again. That will be the main problem. Actually, he'll do reasonably well. This is not only a critical limb, but it's also precious limb now, having had almost already one limb gone. So definitely he needs something doing. And I think he's got a good outflow and inflow. So I think he'll be an ideal candidate for bypass. From where to where will you do the bypass?
Sir, from
Iliopopliteal. Good. Iliopopliteal bypass. And what will be the conduit of choice? You go for either Dacron or PTFE because that's the only one which is going to have a good length.
Okay.
And because it's going to cross so that's one of the options available here. And what are the pre-operative investigations you'll do? Did you do an echo in this patient? Is the echo fine?
Yes, sir. Echo is fine. Echo is normal.
Why do you want to see? Most of the time we see that these patients who undergo amputation, they die within, many of them are dead by 5th year. Why is that so?
Patient will be bedridden, sir.
And, because any amputation increases the cardiac workload, and higher the amputation, the workload is more. And a patient who has a bilateral amputation, the workload on the heart is so high, they don't survive for long. But I've had patients who had bilateral amputation, but they still continue to smoke. So that's the reason why you should avoid amputation at any cost in this patient, and make sure he doesn't go back to smoking. And there are a lot of new drugs which are available, and you must keep that in the back of the mind. And what are the other once you've done a bypass, what are the other things you will apart from cutting down the risk factors, especially smoking, controlling hypertension, and so on? What are the other advice you have to give this patient?
Instead of smoking, we can give any nicotine replacements.
Then
nicotine patches, nicotine gums.
Yeah, nicotine gums. But now there are centrally acting agents which are available, which are very good, medications to stop smoking. It's called silnicrine. So it comes as Champix, and I've used it in a lot of patients, and it's quite good. And one important tip I want to tell you: whether if you take a vascular surgery, don't ask the patient whether he has stopped smoking. Ask the patient's wife, and they are the only ones who will tell this. Even today, I had a patient. Come with me. I know they are lying because they can never stop smoking. The problem is the patient. It's not the patient's fault. It is the addictive potential of the tobacco. And unless the patient completely cuts on, whatever heroic surgery you do will block, and you will have a patient coming back to you, and it's a headache sitting on your head. So this patient must be made to this thing, and hopefully you'll avoid smoking. So apart from this thing, and I think this one candidate, because he has a reasonable runoff, I wouldn't say brilliant runoff, I think he has a good chance of doing well in the long term if he cuts down the thing. And I think that should be it. Okay.
So as Prakash said, this is a good patient for a bypass. So you take a PTFE or a Dacron to the popliteal artery. Have you heard of something about St. Mary's route or something like that? Yes. Have you heard of something like that?
No, sir.
Because when you are taking the prosthetic graft to a lower vessel, particularly popliteal artery, or rarely we take below the knee, there is a chance of this. There is a increased neo-intimal hyperplasia. That's a major issue producing that early closure of that vessel or graft. So to prevent that, we put a vein patch in between the graft and the innate artery. So that's called a St. Mary's boot or something like that. Okay, that's one option. You take a vein, you stitch to that vein to that graft and stitch the artery. So a vein interposition graft is placed in between so that prevent or delay the neo-intimal hyperplasia. Yeah, that's it. So how will you follow up this patient? You're on a beautiful bypass. As Prakash said, smoking is the major issue. The patient has to give counseling. The bystander has to give counseling. Patient has to be educated that no smoking. If you smoke again, it will rethrombose immediately, and you have to give good medications. You have to give good support to the patient. So that's one thing. What are the other measures to prevent the graft occlusion or better patency?
So we have to give medications for the patient.
What medications?
So we can give statins, sir, like atorvastatin or also statin.
What is the most important drug? Which is the only proven drug which maintains the graft patency?
Vasodilator, sir.
No vasodilator. The best drug, the must drug is the ecosprin. All these patients should get ecosprin because ecosprin is the one which has a proven potency that it maintains the graft patency. All these patients has to get lifelong ecosprin after bypass. Okay, then you can give statins, then you can give silosazole or whatever it is. Good hydration, promote walking. They should walk, then only the graft will work. And control of diabetes, control of hypertension. That's a must.
Yes.
Okay, that's about Kanagavel, sir.
I think, sir, thank you, sir. I think sir is not. Kanagavel,
Okay.
sir. Can we close, sir? Can we close?
Thank you very much.
Yeah,
Manoj, do you have any questions to the faculty, man?
Reverse questioning.
Yep.
You have a reverse questioning? Yeah, you're free to ask.
Have any doubts or any questions?
Yes. Any comments? Because we are not examiners. Anyway, you have done a good well. You have done very well. You deserve a pass. No doubt about that. If
I have a question, sir. Is there anything called critical limb ischemia of the upper limb, sir?
Yeah, definitely, sir.
For what is that, like ABPI? Do we have anything?
It's not ABPI. There's blood pressure is at a level less than 70, or patient is symptomatic. Any evidence of rest pain, any tissue loss, it is any minor tissue loss. There is critical limb ischemia in the upper limb, and we should be more aggressive in the upper limb than the lower limb.
Thank you, sir.
Thank you, sir. I thank Dr. Shikma sir, Prakash sir, Jacob and Prabhu for contributing today.
Thank you. Thank you.
And I see Jailal sir staying all through, and a few of the faculty have left already. It's very late, I guess. So we are planning for GA track session or probably endocrine session.
Yeah.
Depending on.
We should be thankful, Jailal sir. Today, Jailal sir sit for the whole time because now he's free. He's quite relaxed.
Unless he is tied up with some transport or something, even I would say transport, he will be available with us.
Yeah,
Operating maybe I will mix him. Otherwise, make time to sit in the class. I don't know. I have to learn from him.
For the last 1 day, he was traveling throughout India, some North India, South India, Northeast.
So finally, he's back to Kanyakumari.
Yes.
Will be much benefited when he is available in the department.
Yeah. Now he is quite relaxed and smiling always.
Then he has other projects coming up. Bigger responsibilities coming.
Yes. Maybe WMA.
The WMA, he's not for it, sir. He's eyeing something very big.
Great. Let us.
Thank you.
Thank you very much, Prakash sir. I think we will take the liberty of disturbing you more often whenever we have a
Sure. It's been a very pleasure meeting Srikumar after a very long time online, and we all go back long time. So And I thank Dr. Jailal for being with us today. And I thank the opportunity, to be with you. Both the PGs did very well, and I'm sure you'll do very well in your final exams. Actually, I think it usually comes as a short case. So don't complicate things by, keep things simple. That's one of the attractions of vascular surgery. The diagnosis is straightforward. The treatment is straightforward most of the time. Okay, we don't have
Thank the guide of the candidates also.
Yes.
Srinivas did better of class.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you very much, sir. Thank you for students. Thank you, faculty. Thank you all the residents and faculty watching in the YouTube. We'll meet next week with possibly an endocrine disorder session with thyroid, both the thyroid for the next question. Thank you very much.
Thank you.
Good night, sir.
Thank you.
Nice.
Thank you.